All right, so here I am. I'm going to talk about this project that we're doing in Camden. So I know that there was a lot of interest in it. We've already talked about it some, but I'll give you a little bit more detail. And then, of course, we'll be opening up to discussion later. So this is joint work with Amy, who just spoke, Sarah Tobin, Annetta Zhu, and Jeff Brenner. And so here's a big picture of Jeff. Jeff, I'm a big fan of Jeff's. He won this MacArthur Genius Award. He was written up by Doyle in the New Yorker. And his mission is, and the mission of the Camden Coalition of Healthcare Providers is to improve health of Camden residents while reducing healthcare costs. And now this coalition includes healthcare providers and community partners. They're running an ACO. They have a bunch of initiatives going on at the same time. But he's celebrated for this idea of hotspotting. And so it started off as figuring out where in Camden all the costs were coming from, so like census tracts, and then trying to deliver care at the places where all the needs were arriving at. And then there's also this idea of hotspotting at the individual level, which is what we're doing at Camden. So as Amy said, 1% of people in Camden account for about 30% of the healthcare costs. In the US as a whole, about 5% of people in the United States account for half of our healthcare bill. And so there's this notion that if you could figure out how to provide care better for those patients, then you would actually be able to save money, improve lives at the same time. Now, normally if someone's called a genius, and if I were called a genius, I'd be like, finally, someone's recognized my genius. My program obviously works because I am a genius. But Jeff is a very data-driven person. In fact, that's one of the reasons why he is lauded. And so what he wanted to know is, actually, does it work? So he partnered with MIT and other researchers to do a randomized evaluation of his program. So this will be a sort of instantly credible, similar to Oregon, an instantly credible analysis of whether his program, this flagship program, works. And then, of course, we'd want to know if it works in other places, if it does there. So it's the Link to Care program, it's called, and it's a care management program. So here's a home visit. It's an extensive home visit program. It lasts at least 3 months for each of the super utilizers. The target population are adults. They're high utilizers, that they have 2 inpatient admissions in the last 6 months. They have at least 2 chronic conditions, but most have many more, and that they're medically and socially complex. And then so a lot of care management looks at super utilizers. What the program is known for is the intervention. So they have a multidisciplinary care team. They have a number of people on the team, about 9 people on the team that include nurses, social workers, health coaches. They also have people that oversee both teams that they have. So, and there's psychologists, physicians. And so this whole team is taking an interest in each of the super utilizers. They're doing a number of home visits. They're accompanying patients to their doctor's appointments, so they'll send a nurse with the patient to the doctor appointment. If you had the conditions these people have, where you have 9 conditions, you're on 18 medications, you would want a concierge to help you figure out what to do. And this is exactly what this approach is doing with a population that's largely on Medicaid, and that they, like you and I, we would really benefit from this kind of intensive support. And then, but the other part of it, so there's a clinical component to it, right? These are all clinicians, but then there's a social component. And so they're trying to improve the lives of patients both on the social side as well. So that includes housing assistance. It includes applying for identification, so then you can go apply for other help. It includes applying for food stamps. I like to think that the US healthcare system is so expensive that we can treat the poverty of these patients and still save money. Because if you have someone going in and out of the ED and not able to take care of themselves with their treatment regimen, one reason could be because they don't have stable housing. So that's one, if we're so good at improving the healthcare system and making it more efficient, that might no longer be true. But at the moment, if we can treat people's poverty, these super utilizers, it could actually improve their lives and save money at the same time. So how does it work? So as Amy said, they were already enrolling people in their program, and they do that at the hospital. So they have a data feed that says, hey, these are patients that meet our eligibility criteria. Why don't you go out and approach them? They had capacity constraints. They couldn't treat everyone that came into their triage system. So what we did as part of the study is that we helped raise funds for extra enrollers, so that they're now not only enrolling people that will go into their program, but they're enrolling people into the study. And then after they consent the patient into the study, they do a baseline survey to figure out some of the things that we can't figure out from administrative data. and then they do the randomization, and then they let the person know whether they're in the study or not, whether they're in the program or not. So like I said, these enrollers were already good at enrolling people into their program. Now they're enrolling people into the study. And they're enrolling twice as many people as they used to, but of course half of them go into control and then half go into treatment. So that's logistically how it works. The consenting, the HIPAA requirements are aided here because we're getting people to consent at the time of the study begins. And then in terms of service delivery and the process monitoring, I don't expect you guys to see this. I'm just pointing out that the Camden Coalition is very data-driven. So they have dashboards that monitor how the program is going, how the study's going. So this here is talking about how many days to a home visit. So you're supposed to get there within 7 days. Do they meet that? And so they were sort of missing that a few times, and they put every form in, and they see that they're able to get that. These are the number of people that are getting into the study, and that's if you would be worried if there was a big spike down in that, and so they're monitoring it week by week, and we're helping that to some extent as well. And then one thing that I was asked to talk about, because this is important for partnering with you as well, is how do you get the outcomes? And so one way you could do it is to survey people, and that's expensive, and we do worry that if we follow the treatment, we're treating the treatment group, that we're going to be running into them very often, and so we're going to get outcomes for them, but then if we're not following the control group as extensively, you're going to have attrition in your sampling that's more in the control group than it is in the treatment group. So surveys are useful, especially for things that are hard to measure with administrative data, but they're expensive and they run into that problem of attrition bias. So we use largely linked administrative data. So in Camden, they have a health information exchange, in part because of the efforts of the Camden Coalition. But here we have data from all of the providers around Camden. So we're able to measure utilization, not only if they come back to the same hospital in which they were enrolled, but the other hospitals in the area. And then I've worked with the New Jersey Department of Human Services to link our subjects to their welfare receipts, so food stamps, general assistance. And because we expect the program to sign people up for these types of benefits, we're trying to monitor whether or not that actually gets done. And so that will be one of the ways we show what did the program do for people in our treatment group and our control group. Right? We can always measure in the treatment group whether there are home visits and so on and so forth, but for the control group, we don't see what the baseline rate of, say, getting signed up for food stamps would be in the absence of the program. But here we are able to do that with the RCT and administrative data. And then it's important for us to have mortality data as well, so we're linking our patients to the National Death Index from the CDC. And one of our main outcomes that you'll see if we registered the trial, as you should do, and one of our primary outcomes is the readmission rate to the hospital. But of course, if people are passing away in the meantime, then they won't be readmitted either. So we want to have a composite outcome of do they show up in the hospital or do they, or is mortality changing the way that we should be measuring that altogether? So that's important. And then in going forward, we've had the consent to link people to their Medicare records, Medicaid records, so to get an even broader measure of their utilization and check on our health information exchange, Medicare and Medicaid data also provide that opportunity to do so. So, in the end, what I want you to take away is that we've been able to partner with a number of providers. I have a number of other RCTs in the works at the moment. But this is a good archetype of what we looked for. So we have data-driven partner that has administrative data. And then we have this, the mechanics of it. So we're consenting people as they get into the program. Then we're doing a baseline survey. We randomize them at that time. And then we're tracking both what happens in terms of the treatment intervention, and we're tracking what happens in terms of health outcomes. So by comparing the health outcomes, like utilization and mortality across the two groups, we're able to say whether it has an impact on people's lives. And by tracking what the Camden Coalition is doing for patients, we get a better sense of what that intervention actually is. And then there's this question of what we call external validity. So the issue with RCTs is internal validity. We have an amazing answer for what this Camden Coalition can do for patients in their own program. But the question then becomes, well, will this work in other places? And so after we do this program, there are two things we'd like to do. One is figure out if this package of care could work other places. And the second part would be what parts of that package are the ones that are driving outcomes. And this will be the first question that payers will have, is that this is a very high-touch program. Could you do it for half the cost. And so what we decided to do is we'll use the big sledgehammer. We'll test whether that big sledgehammer works, and if it works, then we can try to unpack that in future research. If it doesn't work, then we would be going back to the drawing board of what should work. So that's the goal, and we'll be getting results out in the future, and I'm hoping we'll see you all in a future conference like this, and we'll be describing the results like Amy did. All right, that's it from me. I'm going to hand it over to Marianne.